Thank you so much, Lara, for having the time to come and have a bit of a chat with me. I received your book.
Good.
It's amazing. I'm
Oh,
just kind
thank
of
you.
like flicking through it, and I'm just also amazed with like the amount of quality of the different books that you have done so far. We've got the repair, period repair, and the
Yeah,
hormone repair manual.
yeah.
Um, Talk to me before we go even
Okay.
into topics. I know that my audience is big around health, obviously nutrition, metabolism, and improving health, fitness, longevity, all of the things. And a good proportion of my audience, even though there's like a bit of a balance between females and males, females is a big number.
Yep.
And I know that a lot of your work has been dedicated to research women and their hormone health, as well as like everything that has to do with hormonal health, metabolic health. So before we delve into specific questions, I'd love to hear a little bit of your interest of why you have chosen to research and work around the entire like who like women overall,
Yeah.
and
Yeah.
why mostly you tend to dedicate a lot of part of your work around menopause, perimenopause, and how these influence so much women's health, especially at midlife.
Yeah. Well, I'd say actually my interest in my content is around women at any age. Of course, my second book, Hormone Repair Manual, is about perimenopause transition specifically. And of course, I'm interested personally because I am in menopause or past menopause. So that's, of course, interesting. But more broadly, why I'm interested in female physiology is through my lens as a biologist. So before I became a naturopathic doctor, I was an evolutionary biologist. I actually did some research. I published a peer-reviewed paper on sex differences in foraging behavior of animals. So I actually recently went back and looked at some of those papers that I wrote, expecting 30 years ago and expecting them to be terrible. And they were actually very interesting. So that's good to like know that my younger self was doing some interesting work already. I could see a lot of the ideas coming through already. In terms of reframing, I guess a lot of what motivates me is just to reframe and actually understand that in lots of ways, female physiology is the default biology. I mean, I know we always kind of get it has been presented as, there's biology, there's human physiology, and then there's the female version, which is kind of this like extra side issue. And obviously, both male and female are the normal default version of human, but I'm very interested in female physiology and normalizing it. That this is how we're cyclic beings. This is how, yeah, female biology works. There's nothing wrong with us, but we do require a specific conversation. The way I like to phrase it is actually male biology is actually a little quirky and different, whereas, female biology and physiology, yeah, just has some things going on. Like in terms of metabolic health, I could just bring it into that a little bit if you like, because metabolic health is hormonal more than anything. It's hormonal, it's nervous system. It's, of course, this is why my next book, I write all about female hormones. This is, a book about the hormonal aspects of metabolic health, felt like the logical next step. Females, especially women of reproductive age, so younger women, younger than 40, say, have a few things going on. Like they actually have some superpowers in terms of things that really matter, like insulin sensitivity and being reduced levels of visceral fat compared to men the same age. That's a lot to do with estrogen, the superpowers of kind of estradiol in terms of mitochondrial health. It's also there's some other reasons I think that young women are just so like good metabolically in lots of ways, but at the same time do tend more to subcutaneous fat. Of course, that's also a female superpower. We have more subcutaneous fat than men. We're supposed to. And actually, subcutaneous fat, especially in young women, women of reproductive age, is highly resistant to fat. Like the body defends that, like its life depends on it. And in some ways it does, because those subcutaneous fat reserves are to make a baby. So the body's like, this is non-negotiable. we have to hold on to this. So I guess one of the messages in my new book is prioritize metabolic health over, body size to some extent. I mean, I'm not saying body size doesn't matter, but it's just sort of a reframing around that. And also just a celebration of, for example, bum fat, this gynoid type subcutaneous lower body fat, which in women is another superpower. Like it's anti-inflammatory. It's potentially a depot for omega-3 fatty acids. Like it's a good thing. And I have a section in the book called Don't Break Your Heart Trying to Lose a Big Bum, because that just feels like a very sad thing to do as a young woman. Yeah.
Awesome.
Yeah.
Now, I do have like quite a few questions that I'd
Yeah.
love to go over.
Yeah.
And I think you covered the first one, but I was really interested to hear a little bit more about your recent book that's called Metabolic Reset.
Yeah.
Is it aimed at a particular audience? I know that once I was reading around it, you do you do tackle a lot female. Why is it female
Well, actually,
mostly?
so in Australia, it's called the Metabolism Reset. Everywhere else it's called Metabolism Repair for Women. So it is exclusively for women. Although
Yep.
I've had men read it and say men can get something out of it, because of course are some commonalities. It's for women with insulin resistance. That's actually who it's for. And the thing about insulin resistance, we can talk about that a little bit more, but it's, as you know, it's not uncommon. It's at least, conservative estimates are 40% of the general adult population. It's higher in certain populations, certainly higher with older people. Certainly after menopause, it's much higher, like very high by that point, I would say. So that's who the book is for. Women with insulin resistance, because a common symptom of insulin resistance, I would say, is abdominal weight gain, or like, that's like one of the main symptoms. A lot of these women may be looking to lose weight. That's one of their goals. But just for full clarity, it is possible to have insulin resistance and have a kind of smaller body size as well. So it doesn't track exactly. It certainly doesn't track exactly with BMI.
Mhm.
That's who the book is for. And so because it's about insulin resistance, it'll be very relevant for anyone with polycystic ovary syndrome or PCOS. Definitely the menopause transition is a time of increased risk of insulin resistance. So it's for those women. But yeah, it's not necessarily, no, it's not for everyone.
Okay. Um, why the big focus on insulin resistance and metabolic flexibility? Can we define those terms first
Yeah.
and say sort of why is so important to look at these two things?
Yeah, great question. Well, because that's where well, first of all, I will define them, but first I'll say the reason I think it's so important to focus on insulin resistance is because it's the upstream cause of all the downstream negative effects, like increased risk of heart disease, high blood pressure, potentially mental health symptoms, and potentially weight gain. I mean, people have different opinions about this. Obviously, the conventional narrative has been that weight gain comes first and leads to insulin resistance. I'm definitely in the camp where I think, at least a lot of the time, the hormonal condition of insulin resistance comes first
Hmm.
and promotes weight gain, especially abdominal weight gain. It doesn't promote the healthy gynoid or bum fat that I've just been talking about. For example, subcutaneous fat in women is different, but it does promote that unhealthy type of visceral fat, that abdominal weight gain. And in terms of what it is, so insulin resistance is a hormonal condition associated with, a reduced sensitivity to the hormone insulin, and importantly, chronically elevated levels of the hormone insulin. It's also called metabolic syndrome or hyperinsulinemia. That just means high insulin. It's also sometimes called prediabetes, but I am lately just like distancing myself from that term, because the reason I don't like prediabetes in this context is because everyone immediately thinks high blood sugar. They're just like, well, it's about high blood sugar. And then I had someone in my social media comments say to me, well, like, I know, she was like logically thinking, well, I must not have insulin resistance because my blood sugar is low sometimes. And that is really an important point, because it is entirely possible to have normal or even low at times blood sugar and have insulin resistance. In fact, a tendency to reactive hypoglycemia is a symptom of insulin resistance. So this is where, and I've had so many patients to like say, oh, my doctor measured my blood sugar, it's fine, so I must not have insulin resistance. So I'm really trying to move the needle on like changing that conversation. The real symptoms of insulin resistance are things like high triglycerides, high blood pressure, low HDL, highish ALT, or it's associated, that's a liver enzyme associated with fatty liver. Anyone who's ever had their doctor casually mentioned to them that they have fatty liver disease or fatty liver, that is almost always insulin resistance, although there in a few cases it can be from something else. But you see, it's common, right? These are common things. And yet I don't know with your work with clients or patients how often people have it or like deep in the middle of this hormonal condition and don't really have the language around it or to kind of know what's happening. And also it's reversible. That's obviously a very important part of all this. Metabolic inflexibility is closely related. Metabolic inflexibility in a nutshell is about a reduced ability switch between burning carbs and burning fat, but in practical purposes, like for like what it really means for people with insulin resistance almost always is a reduced ability to burn fat. So people get locked into carb burning. These are people, this is not a pleasant place to be because for one thing with insulin resistance, there's reduced glycogen storage in the liver. So these are people like their body between glycogen and all the fat stores, there should be like so much energy to be able to sort of keep going, like for a normal amount of time between meals. Obviously, it is normal to get hungry at a certain point when you're ready for your next meal, but this constant hunger and needing to like have a muesli bar just to, go for a walk that's metabolic inflexibility. That's being locked into carb burning just to have energy. It's not even about, this is like a message in my book. It's not a willpower thing. For people, when they are reaching for starchy kind of foods to survive, like to keep going, that's metabolic inflexibility. It's not supposed to be like that. And I guess my message to anyone listening, if they found themselves kind of locked into that carb burning, carb craving, there's a way out of that. And the way out of it's not willpower. Like there is a way to feel better and achieve, I talk about in the book, ongoing kind of zest or energy and satiety, like this ongoing feeling like that you have enough energy, between meals. And obviously that depends on the meals being structured properly so you're getting enough protein and all the things. But yeah, the need to kind of constantly snack between meals is a key symptom of metabolic inflexibility and insulin resistance.
We know that the energy consumption, energy expenditure, even like eating behaviors are things that they are not necessarily fully attached to conscious decisions, but also there are areas that are conscious decisions. So there are parts of our metabolism or like things that happen in our body that drive certain outcomes, certain behaviors, certain reactions, or even like certain things that we cannot control. But there are others that are partially conscious. Like we are like a combination of both things. And sometimes things like certain habits and behaviors are potentially conscious, but they could be coming from an unconscious point of view or like a deep rooted learned behavior that once was conscious and it kind of became unconscious as years went by. Or like when we think about people who has had very rough experiences or trauma, those things sometimes at the beginning they may act as protective and make conscious decisions around what they do, and that relates to food as well. But over time, because they continue to use the same protective mechanisms, becomes unconscious. So my pretty much what I'm going to ask you is more about some of your statements in your book talk about certain areas like energy balance, as well as eating behaviors, energy expenditure isn't necessarily conscious or under our control. So can you expand a little bit on that?
Well, it's just, I don't think we can, a lot of people have tried for a long time to micromanage energy balance And I just like the research, a lot of the, especially some of the latest research, is that's just not workable for a lot of people. I think it comes down to, I mean, I hear what you're saying about, yeah, I mean, so I think you're referring in chapter one, I talk about how largely eating behavior is not under conscious control. I mean, it is to a certain extent, but big picture comes down to this. If people are hungry, they're going to eat. Like we are. I don't mean they, I mean all of us. Like at some point, if there's
Yeah.
hunger, if people are hungry, we will eat because we're animals. This is my biologist lens coming through. It's a wishful, it's just imaginary thinking to think that people can withstand that for very long. So, and I'll likewise, I guess on the other side of the equation, conscious energy expenditure with exercise is not really, that's not how it works. So that the science is pretty clear on that actually now. Exercise, like movement, is highly beneficial for all the reasons that I talk about in the book, building muscle, because muscle is a metabolic organ. Muscle is a hormonal organ, endocrine organ. It's got a lot going on. There's lots of mitochondria in muscle, which is like mitochondria are the central players in metabolic health. So, and moving the body is really good for the nervous system. So there are lots of reasons to engage in some kind of regular movement. I think some people are more interested in that than others. I've just lately been thinking about how some people just don't enjoy exercise. And I think we have to also make space for those people, but we can come back to that. But in answer to your question, this old narrative that you can burn calories, you can sort of manage your calories coming in. I know you maybe, you and I might disagree on some of this, but and then the idea that you can then burn those calories with exercise, that equation, it's a nice idea and it looks good on paper, but like the biology doesn't care about those numbers, right? Like, and actually what we know, I would say it's even more the case in women, but definitely for all humans, the work from, I think it's Herman Pontzer, the scientist, made that startling discovery that when the body engages in a lot of exercise, it actually just dials down energy expenditure in other areas to try to stay at about the same amount of energy expenditure daily, which
Yeah.
totally makes sense from an evolutionary biology perspective. But our human ancestors could not have afforded to burn off all these calories if on days they had to move a lot. Like that's just not, the body's much more conservative in terms of how it does things. So given how difficult it is to kind of consciously micromanage those two columns of numbers, I mean, I just presented a different approach, is like, let's lean into the complexity of the system and just understand that there's lots of factors, I call them signals, feeding into both energy. Like a good step is actually to be able to burn more energy, like actually tap into your fat stores and be able to burn those for energy. So overcoming metabolic inflexibility is a great first step. And hand in hand with that is finding a way to feel less hungry. And that, like, finding a way to achieve satiety on an ongoing basis is largely about food. I mean, I think we both agree protein plays a huge role in that. Most everyone in this space, we can all agree on protein as promoting satiety or satiation. So that's a great tool or lever that people can use. They can use the timing of protein a little bit throughout the day to kind of help with that. But protein in the morning is hugely effective. So, but it's not just that, right? Like if it was just protein, that would be great. I mean, that would be a nice, simple solution for everybody. But there are lots of other factors that affect satiety. For example, and this is now my naturopathic doctor angle on things, the gut microbiome has a huge effect on hunger and satiety signaling. It's quite bizarre, actually. I mean, you probably know the gut microbes make neurotransmitters. They're communicating with the brain through the vagus nerves. There's a part in the book where I talk about, it's a bit of a, it's a bit of a simplification, but it's pretty accurate, pretty close to what the science is showing. We are hungry for what our gut microbes want us to eat. So like they can change over time. So this is why this accounts for some of the lag time. Like when you start eating something new, at first you might be thinking, oh, but I miss those chips. Like that, in part, that's your microbes going, where's that food that we're used to having? Like, you need to, and unfortunately, there's lots of other ways to affect gut. I mean, gut changes with diet over time, which is, very important. But also, as I describe in the book, there are, different underlying gut conditions like small intestinal bacterial overgrowth or SIBO can definitely drive through several mechanisms, worsen insulin resistance, worsen metabolic inflexibility, basically make people hungrier. And what a couple of the patient stories in the book, I talk about like this one patient, she's like, she knew she shouldn't have sugar. She kept having these sugary snacks every afternoon, and she's like, just, tried to stop them. And then finally, we identified a gut condition and fixed that. And she's like, wow, the sugar cravings just went away. I mean, that's just one example. It's not going to be like that for every person, but I think if we set the baseline, it's not normal to like feel hungry between meals and be craving sugar all the time. So then troubleshooting what has to happen to escape that feeling and kind of get your life back, basically, so you don't have to be constantly thinking about food all the time.
So in your book, maybe just based on your experience, how do you tackle that? Like if you have these issues with like huge amount of cravings, hunger dysregulation, there's like difficulties to lose weight, do you attribute that automatically with an issue with your metabolism or your hormones, or do you think that could be an answer that goes way beyond that? Maybe an emotional component, like people that are emotional eaters, stress eaters, that could be someone with ADHD or someone that has a lot of issues with, I don't know, maybe it's just like they have a very hard time managing stress or sleep deprived. So how do we actually tackle issues with hunger and cravings and identifying which one is the actual cause, whether it's diet, is it hormonal, is it genetic, what is it, and how do we tackle this?
Well, that's the whole book. That's basically the premise of the whole book, is troubleshooting that. So I do talk about ADHD actually, and I do talk a lot about the nervous system. Is very involved. I have a section on emotional eating. Unfortunately, emotional eating is quite a nebulous, vague concept that can encompass a lot of
Yeah.
things. Under that, I do also talk about a little bit, and I give the example actually of a scientist, some quotes from her, where she found that, for years she thought she had emotional eating. And then in her case, discovered it was actually ultra-processed food addiction. So there's quite a bit of research on ultra-processed food addiction. It's especially in women, so the overall rate in the population is a lot higher than anyone expected. In women, especially older women, it's probably getting up like 30 or 40% of people or higher, of women who are experiencing some of these difficulties, like the constant hunger, the constant cravings. Food addiction could be a factor for them. The gut can be an issue. So like I said, my book is a whole, like the basic problem that the book tries to solve is that fundamental, like because of insulin resistance or metabolic inflexibility, like that inability, like that feeling hungry all the time and having low energy. And then in terms of what is required to fix that, that's where the troubleshooting comes in. So I think there's like 25 metabolic obstacles that I identify in the book. So I've already talked a bit about gut. I talk about thyroid issues. I talk about food sensitivities. I do have a chapter on food addiction. I talk about female hormones. I talk about the nervous system. I do have a couple places where I talk about ADHD. So because it's individual, right? So it's troubleshooting. And I framed it as metabolic obstacle because people can't, like, we can't expect people to like micromanage we've already talked about how it's hard to micromanage. It's hard enough to micromanage kind of calories in, calories out, but you also can't micromanage every other thing that I'm talking about here. So you have to more put it through the lens of, I don't want any micromanaging involved, actually. Like, I think it should be about what's standing between me and feeling kind of more satisfied and having more energy. And looking at the list I survey like the various metabolic obstacles, and I'll just, say again, if there's a gut issue, that's a big part of it. That becomes kind of a priority. There can be, one of the metabolic obstacles is even just, it's a silly one, but it's super common, at least with my patients, not being able to, for whatever reason, not knowing how or having the time to cook at home. Cooking home cooked meals is actually, I'm sure you'd agree, like hugely important in all of this. But it's often not enough to just say to people, oh, just please go ahead and do that. Like, you just think, okay, what's the reason, that you haven't been able to prepare these whole foods at home? Because, switching to whole foods is, yeah, I think, a critical part of all of this. And I provide a patient story about that, just a patient who just really didn't want to cook at home, found a way to do it. I've shared on my own social media that I really do not like cooking, but I do it, especially lately since my husband's gone back to university. So I'm just like cooking every meal, which is hard, but important. So yeah, I think that in answer to your question, like, how does someone figure out, yeah, it's troubleshooting. And ideally, if you have a practitioner to work with, that can help. But I structured the book in a way that I do hope people can come away thinking, well, at least, okay, another example is circadian rhythm. So circadian rhythm has a huge impact on metabolic health. And it's so funny, Astrid, like if you've seen this in the research papers, but whoever the group of scientists are that they're looking at, they tend to think that's the whole, so the people looking at the gut microbiome are like, okay, metabolic health is all about the gut microbiome. People looking at circadian rhythm are like, this is everything. This explains so much, because a misalignment of circadian rhythm really does affect the nervous system and the hormonal signaling around metabolic health. And so that's an easy, like, I invite people to try to identify if their circadian rhythm is misaligned, not just misaligned with the actual daylight outside, but misaligned between, what the brain is doing and what the circadian rhythm of the gut and the liver are doing, and trying to align those properly. And that can provide pretty quick payoffs. Those are, in terms of ranking the metabolic obstacles, I put, aligning circadian rhythm is one of the easy, important fixes to do. People could just sort of just start with that as they're, working on some of the other obstacles that they've identified.
So based on what you're saying, I'm really interested in hearing from you around these metabolic obstacles. Where do you even start when you have these range of metabolic obstacles?
Yeah.
To actually assess what the root cause or the root issue is. What is the actual obstacle that you have to tackle if there's so many areas that could be potentially affecting your metabolic health or your overall response to metabolic flexibility, insulin resistance, all of these things?
Yeah, well, I'm not sure what you're asking. So, I mean,
where do you start? So how do you assess what the root cause is? Like, do you use a questionnaire? Do you run like specific tests? What does it need to happen in order for you to know exactly what the main action has to be to fix the problem, if that makes sense?
So, I mean, that's the premise of the book. And I do talk about assessment. So chapters 8 and 9 are all about, more quantitative assessment for some of these things. And then, for example, how to assess, for example, if there's a clinical thyroid problem, like if someone has Hashimoto's, then that, becomes one of the more priority things to tackle. So Hashimoto's thyroid disease. And then in terms of ranking the other obstacles, metabolic obstacles, I mean, I guess my one takeaway from the book is, like I sort of just had a few minutes ago, there's no, and I think what you're asking too, is like, you can't tackle like 5 at once, because that's just too overwhelming. And that's obviously where a lot of people are not able to continue on their journey, because they're just trying to, make too many changes at once. So it is about, prioritizing for the individual, maybe with their clinician's help, but which of these, like let's say they've identified, for example, circadian rhythm is out, there are gut issues, there's a food sensitivity to dairy, and they don't have enough hours in the day, and plus they need to move more, like, sort of that might be a common 5 sort of things. So you would start with, I often say, start with circadian rhythm, because that just kind of moves the needle on everything else. It's as soon as you pull one lever or make one change by getting outside in the day, timing your meals so you get protein by 10 a.m. and you stop eating by like 7 p.m. That you could frame that. I mean, that's a circadian rhythm treatment. As soon as you start to do that, people will often find that some of the other things will, start to improve. And then, then they can sort of maybe tackle some gut treatment, or certainly with a food sensitivity would be pretty high. I classify all the metabolic obstacles as easy or difficult, high or low priority. So a food sensitivity, I'd say, is in my clinical experience with my patients, a food sensitivity is pretty high priority, and it can give a huge payoff. So if someone has identified, for example, a dairy sensitivity, which is only like maybe 20% of the population or something. It's not the majority have that, but if that's been affecting their periods and also causing fluid retention and potentially worsening premenstrual cravings, then switching to a different kind of dairy or getting off normal cow's dairy can just make everything so much easier. Suddenly they're not having those distressing symptoms. They lose some fluid. They naturally feel less hungry. That would be the method of prioritizing. I haven't put it in the context of a, specific quantifiable quiz. I do present it in the book, talking about each kind of obstacle one by one, and then, as I said, sort of inviting people to choose the high priority ones.
You talk about Cibo as one of the things that are correlated to your gut health and your gut microbiome. How huge is this, and like in terms of the priorities, where do you put this one into priorities to tackle?
Yeah, pretty high actually. So that's a concept.
If we can define it, probably a lot of people hear this buzzword, oh, you have Cibo, but they have no idea what that means.
Totally. Yeah, it's a good one to bring up because it's a common condition and it is a pretty major driver of insulin resistance. So it is a situation where the normal gut microbes, bacteria, have taken up residence, basically moved up into the small intestine. So it's called small intestinal bacterial overgrowth. There are not supposed to be a lot of bacteria in the small intestine. It's a very unpleasant situation when it occurs, and it creates a lot of digestive bloating. Bloating would be the primary symptom, but it also drives intestinal permeability. And that feeds into something, it's a term which any of the more kind of sciencey viewers or listeners might want to know, which is metabolic endotoxemia. So this is that means endotoxins are the toxins from the gut bacteria. It's called lipopolysaccharide or LPS toxin entering the body, the circulation in part, the portal vein straight to the liver where they can induce fatty liver, and even straight into via the mesenteric lymphatic system straight into visceral fat where they can create inflammation and hypertrophied visceral fat, which then starts sending all these distorted, weird signaling in terms of leptin and all the satiety hormones normally sort of happening between the visceral fat and the brain that gets all disordered. So the science is pretty strong around the intestinal permeability or metabolic endotoxemia being a driver of metabolic dysfunction, insulin resistance, fatty liver, and clinically I've just seen it as well. It's one of those things where if you can address or fix SIBO, people will, first of all, they feel a lot better because they're less bloated. Digestive bloating is obviously not pleasant. And then they might then notice downstream from that they're, as I said, one of the patient stories, her sugar cravings in her case just pretty much disappeared. And that might be someone I'm trying to remember the details of that patient's story, but she might have interpreted her sugar cravings as emotional eating. This is what I mean about emotional eating being a really broad, anytime someone has a craving and they don't know why, and they're a bit stressed about it, that can easily just be well, that's emotional eating. But in her case, in this particular patient's case, it's, I think in chapter 9, I provide that patient story, that was from her gut. So that, I'm just a very practical clinician. So I just really, when I've got a patient in front of me, I guess back to your question of how do I gauge, which is the most important thing for me, looking at someone, it's which is the change, step one of this person's journey that's going to move the needle the most, make them give them the most, increased energy. In, the case of insulin resistance, the most kind of reduced cravings and actually just feel a lot better.
You mean kind of like the lowest hanging fruit?
Yes. Yeah. That's another way to phrase it. Yeah, for sure. Yeah.
Okay. And you mentioned that this is a big thing, but when you identify someone with SIBO, what are your main recommendations to fix that if we need to address that?
Yeah, well, so from the conventional perspective, you could probably, speak to this a little bit. This is where the low FODMAP diet, this is why low FODMAP seems to fix a lot of things, right? As soon as you remove, so when you've got, and I don't necessarily recommend a low FODMAP in the long term, but short term, it makes sense that it reduces inflammation. And because it when the bacteria are sitting there in the small bowel, the main thing they do is ferment carbohydrates. And so that, fermentation and inflammation generated from that is a lot of what contributes to the bloating, intestinal permeability, and then all the inflammation that's downstream from that. So another interesting thing, through my naturopathic lens, looking at a low carb diet, which I do talk about a little bit in the book, there's different, people could talk about different mechanisms by which a low carb diet improves health, but one mechanism for sure is gut related. So a low carb diet is essentially a low FODMAP diet as well, incidentally, and it also can actually really knock back the overgrowth in the small intestine. So,
What about fiber?
Yeah,
like,
well, exactly.
Is it lower fiber
It
or
is.
just normal fiber?
So just to put it in context, I don't necessarily love a long-term low FODMAP diet because FODMAPs are also they're the oligosaccharides. There's some of the important fibers that we eat. So the same fiber that would feed the bacteria in the large intestine, which is a good thing, are feeding the bacteria in the small intestine, which is a bad thing. It's just a location issue. So I opened my answer with just this acknowledgement kind of nod to low FODMAP, low carb. They in large part work, I think, by knocking back Cibo, reducing the bacterial count in the small intestine. But there are lots of other ways to treat it. So in the book, I do talk about berberine. As you know, berberine is quite famous for metabolic health. And it has, to be fair, it has a lot of different mechanisms of action. But one of its mechanisms is treating Cibo. And it's antimicrobial and natural antibiotic that kind of knocks back those bacteria. I think with my patients, that's a lot of the time, if they get metabolic benefits from it, I think that's why, because they almost always have had Cibo. But there's other ways to anything that reduces inflammation in the gut, improves healthy motility. This is where the nervous system comes in. So the neurotransmitter acetylcholine is really important for healthy gut motility, amongst other things. It's also a satiety neurotransmitter. So you would have seen in the book, I'm a pretty big fan of acetylcholine and the parasympathetic part of the nervous system. I talk about the importance of choline, the nutrient, as a precursor to acetylcholine. There's other ways it can be supported, including with getting adequate B1 or thiamine, and also troubleshooting, this whole people have written a whole book on the importance of thiamine or B1 for metabolic health. And not to get too far into the weeds on this, but that's one potentially way to treat Cibo. And just to give you, an example of the interconnectedness of this, alcohol depletes thiamine or B1, and alcohol increases intestinal permeability. So alcohol is one of the metabolic obstacles that I list in my book. Certainly I've had patients who are doing everything else right. They've micromanaged every aspect of their life and exercise and diet, and they're still in the grip of alcohol. And for that person, right, that's the obstacle. That's the thing that needs to change. And I'll just acknowledge, for people who are really in the grip of alcohol, and it's easier said than done a lot of the time. It's both.
Yeah. I agree. Now, I think this is a question that is not necessarily coming to ask about metabolic flexibility or insulin resistance, but more so about female hormones and period loss. So we have, you have spoken a lot about hypothalamic amenorrhea in your previous books as well.
Yes. Yeah.
And I wonder whether this is something that usually tends to be quite multifactorial, not just because of energy availability, but perhaps is it genetic? Is it due to extra stress? How do we tackle HA and identify how a woman could be sensitive or not to these different factors? I've gotten females working with me that they tend to eat pretty much a good amount of calories. The energy availability may not be an issue, but they have a very busy, very stressful lifestyle, and they have a bit of a history of losing their cycle in previous years. So how can we tackle period loss, and how do we identify potentially what could be the main thing that is driving this issue if it's not necessarily energy availability?
Right. Okay. So, yep, no, I'm happy to talk about that. That's not really part of my current book, which is totally fine because
I know.
Yeah, that's totally fine. Yeah. So, functional hypothalamic amenorrhea. First, yes, you're right. I mean, it can be induced by stress, high stress, by illness. It's basically, to think about it this way, like it's not a disorder. It's an adaptive, functional, healthy response of the brain thinking, oh dear, like there's something is not good, something really not good is happening right now. I definitely cannot afford to make a baby. So it's about convincing the brain that everything's okay. My clinical experience, so illness is a good example. So someone got really, sick with something, or like was in hospital for a while and like might lose their period, a few months later and lose it for a while. Like it's just as their body like recovers from that. So that's a clear example. Certainly chronic stress in more sensitive women could, cause them to lose their period. I would say the biggest driver though is undereating. And I'm just responding to about energy availability. The thing is, I think women need a lot more calories and potentially carbohydrates than they might realize. Like, I don't know if you can sort of do a calculation. Again, you can sort of do that on paper. It's like, well, this seems like this should be enough, from the exercise they're doing plus baseline metabolic rate, but that's not enough for their brain. Like their brain they just need, potentially more than that. So there is a book out there, which I like mentioning sometimes. It's called No Period, Now What? She recovered from hypothalamic amenorrhea herself. And she's just like, she has this philosophy of just all in, like you just really start eating. Like you just have to stop restricting calories in any respect. And for a long time, like for months to get a period back. So I'll say a couple of things more about why some women are more sensitive than others. It depends on age. So younger women are more sensitive. And by younger, I mean also how many years of cycling they've had. So not counting years on the pill, but how many actual years of natural menstrual cycling do they have under their belt? That's something called gynecological age. Women with a younger gynecological age or just have a more sensitive system. Like the whole system, the brain just gets a little bit trigger happy. It's like, oh, I'm not sure. That seems like too little food coming in. And so, and the other thing to understand about it, there can be a lag time. So someone could be doing a diet for months and like, oh, this seems fine. And then 4 months later, after the onset of that diet, lose their period. Likewise, it can take 6 months to get a period back. So it's really not possible to micromanage that and think, oh, I'll just dial up my calories for a couple of weeks and see. It's like, this is why in the book, No Period, Now What? She does this all in for 6 months. In terms of carbohydrate, like we just talked earlier in the conversation, there's definitely a place for a lower carb diet. So I recognize all the science around that. I think that can be important for some people, but for some women, for young women, it can be a disaster. And I think some of that variation, and yet for some women they're fine. So I think some of it's just genetic ancestry. So I think there's some evidence that we have calibrated our what's called HPO axis, like our hypothalamic pituitary ovarian axis is calibrated ancestrally. So like, if you think about it, like if we had, come from a long lineage of people who ate a lot of grains and were, pretty starch-based in their just, diet, that is going to be, the brain is, I think, potentially looking for a particular amount of kind of starch or insulin signaling to be able to signal ovulation. So there is, it doesn't seem fair why some women, can seem to restrict quite a lot and not lose their period, and some women do. It's just, there's that individual variation. There's also the point, and which I think your listeners probably already know, but that pill bleeds are not periods. So, having a regular withdrawal bleed on a combined method of contraception is not a period, and it's potentially just masking the problem of hypothalamic amenorrhea, the underlying problem.
Yeah, okay. I did see something very interesting in your book that you briefly talk about, which is actually it's most common that we think it is amongst females and I think even in males, because I have spoken with quite a few clients that struggle with this, which is lipedema.
Yes.
This is something that
Yeah.
I wonder, and I would really love to hear from your point of view, like how common in your opinion this is, and can we actually do something about it?
Right.
Can we improve
So
it?
yeah, so lipedema is this painful, distorted, like potentially quite a large amount of usually lower body subcutaneous fat. By distorted, I mean it's like it's not even. So like images in the book. And so I have the section, the lipedema section in Metabolism Repair for Women is in the final chapter 13. It affects, so not my estimate, but the official estimate is it affects 1 in 10 women. So that's a lot. That's
Mm-hmm.
that is a lot.
Yeah.
And it does not categorically does not respond to just typical, weight loss attempts. It doesn't respond to calorie restriction, as far as I know. It's because it's not just, too much fat in the subcutaneous depot. That's not what's going on here. It's actually more related to connective tissue, to the fascia, to the lymphatic system, to inflammation involving those systems. And so this is why, weirdly, there's a genetic connection. There seems to be a connection between lipedema and hypermobility syndromes, which are the connective tissue syndromes of super bendy joints. So that seems to overlap. So that does tell the
Mm-hmm.
story of connective tissue. And so I think, there's a link to a group called the Lipodema Project, which are, doing research. They did a research, they published, I think they were involved in a paper that came out of the ketogenic diet for lipedema. I would also say through my lens, and my patients, you need to think also about things like dairy sensitivity and, anti-inflammatory, like potentially avoiding dairy if there is a dairy sensitivity, looking at ways to reduce inflammation and restore, address, connective tissue health. So that's a really good question to bring up because, of course, you'd be encountering it I've encountered it with my patients. You're going to see it if it's 1 in 10 women.
I do see that you put here that there's something that there was a study done on ketogenic diet
Yeah.
that's called lipo diet.
Yeah.
Do you find that actually improves that condition at all?
To be honest, I haven't had it. I have not prescribed a ketogenic diet for lipedema. I haven't worked that much with it. I have the few patients I've had with it. Like I said, I have kind of more taken the naturopathic angle of, dairy free and, anti-inflammatory strategies that help to reduce the inflammation and the swelling because the condition's painful, right? A reduction in pain is going to be one of the first improvements. You can also, people involve manual lymphatic treatments. Look, I'm not a lipedema expert, so you should probably,
Yeah,
it's
of
such a big
course.
topic. I think I mentioned the group, the Lipodema Project, maybe have one of them on the podcast to talk about that ketogenic study. Yeah, I put it in the book just because I thought it was interesting. It's one of the little bit of research that there is out there on that for that condition, but I have not had a chance to implement that with patients. No.
That's all good. Well,
Yeah.
this has been an awesome conversation,
Yes.
Lara.
Thank you.
I love speaking with you, and we really love to sort of like wrap up with like maybe is there any sort of like specific message or some couple of recommendations of how to do to just feel better, improve your metabolic health, and just live longer, healthier as a woman?
Yeah, I actually want to finish with a little bit different than what you're asking, but like in the book, I do have a whole section on dispelling shame because a big part of my messaging too with the book is that this is, big picture, this is not people's fault. I have a whole section on how like our modern food environment has largely kind of collectively pushed us all into this very weird kind of metabolic state of like a high incidence of insulin resistance. So I want to kind of reframe it that you're not alone. People listening or
Mm,
watching, it's not that you've done something wrong to end up in a situation. If you find yourself in a situation of insulin resistance, it is reversible. And in answer to your question more like what are some simple things, like step by step would be my recommendation. Like pick
okay.
something, one of the metabolic obstacles that is doable. Another, I guess the perfect example, I think we can both agree, increase your protein intake, especially in the morning, let that help to build some satiety and just, feel a bit better in terms of
Okay.
energy. Yeah.
Awesome. Well, I recommend this book for anyone who wants to listen and read all of the things that we have spoken in this podcast, and I think even more. You'll also look at additional resources and like a list of different supplements that you could potentially use to kind of like the cherry on top. You
Yeah.
have to do the basics first, and you have to do the foundation before you even go and rely on supplements, though. But I think that is important. Is there anything that you want to get the audience to take away, or where do they find you?
Yeah.
Any
Thanks.
projects?
Yeah. All right. Well, thanks, Esther. Thanks for the chat. It's always good to talk with you. I'm easy to find at larabriden.com, and all my social media is at Lara Briden. And yeah, we've been just talking about my new book, which has two names, which is a little confusing. As you showed, it's the Metabolism Reset in Australia and New Zealand. It's called Metabolism Repair for women in the rest of the world. So
Awesome. Well,
all right.
I will look forward to releasing this very soon, and I'll share it with you so we can collaborate on this. But
Yeah.
thank you so much for your time.
Thanks, Esther.